National Conference for State of Community Pharmacists of Nigeria. You should celebrate yourselves more. Please put your hands together for yourselves, men of honor.
You see, Rebecca, this reminds me, I was with the chairman on Saturday to a radio program on Nigeria Info. Okay. Of course, you would be amazed how the society actually appreciates the roles of community pharmacists. And of course, as we know, we have these unprecedented and very massive responsibilities that we do in the community. Mm-hmm. We have always been serving as the first aid during emergency, during minor ailments. Mm-hmm. And these have not really been formalized. Mm-hmm. And that is why we are saying it's untapped potential, because a pharmacist is a 7-star healthcare professional. Mm-hmm. And the community pharmacy bridge up together a business pharmacist, a life-saving pharmacist, and a professional pharmacist. So a community pharmacist actually represents the total image of a pharmacist has been trained by 5-6 years in school. So this is one of the strategic roles in which we feel that the potential of community pharmacists will be actually being tapped, and the conference is actually aimed towards ensuring this. I'm very hopeful that at the end of this symposium this morning, the community pharmacists here this morning, we will not go the same, because we have our very distinguished, very resourceful speakers that's going to do justice to this topic. So while we are calling on the Society for Family Health, are they ready now? Okay, while the Society for Family Health is getting ready to do their presentation, we want to call on the National Chairman, Association of Community Pharmacists of Nigeria, Dr. Samuel Adekola, a Merit Award winner and a DSA. Please, let's appreciate him as he come and give the opening speech for this symposium.
The chairman of this very important symposium of the annual scientific conference, in persons of Dr. Shuaib, the Executive Director of Primary Healthcare Development Agency, ably represented by one of our own, Pharmacist Honorable John Henga, Chairman, Hospital Management Board, Benue State. The panelists, starting from the Mission Director of USAID, ably represented also by one of our own, very passionate pharmacist, who was highly instrumental to the planning of this year conference, particularly some of the strategic sessions we'll be holding. I want to specially recognize pharmacist Emmanuel, and I would like you to just stand and just face the audience and take a bow. Please, let's give him a round of applause. That gentleman is a pharmacist par excellence, a passionate pharmacist. Thank you very much. I'm happy that you are even the one representing the country director. I equally want to recognize especially another panelist, honorable members of REP, House of Representatives, Honorable Kakali, Doctor, It's a members of House Committee on Primary Care and Communicable Diseases. He called in last night and tendered apology that he wanted to be here physically. I interfaced with him after one of the public hearings we had, sometimes in July, on primary care. And I saw his passion, which was the reason why I felt he should be part of this discourse. He took me into his office. He was very passionate and concerned about community pharmacy. Honorable Kakali, but this last night he called me that because of the emergency situation that just taking place, a killing in his constituency, the National Assembly today are going to be discussing the security challenges in the country. So, and that he has a motion to raise, and he will want to be there physically to raise this motion. So he pleaded with me that if he's able to got his motion raised and can still catch up with us, that he will want to be here. But he will want to send ahead his aide, who is equally his pharmacist Abubakar. Please, can you stand to take a bow? Thank you very much. Thank you. Thank you. I want to especially also recognize the Pharmacist Council of Nigeria Registrar, ably represented by our own pharmacist Babashir Ahmed, the man I usually call the registrar designate. I'm sure you know. For those who know council, the working of council, that guy is the engine room when it comes to council. He's actually the encyclopedias of the council. So, pharmacist Babashir, I'm glad you are here. Thank you very much. Yes, our major speaker, the guest speaker for section, if you know what it takes me to track down Guanis Frederico, the same man that spoke to, who was a key speaker at the FIP Congress in Abu Dhabi, and the same man was the FIP special guest, keynote speaker at the European Union FIP Region Congress in Ankara. It was from there I decided that he's going to be a key speaker, and I started to track him. But this tracking I started since November last year. He is an executive director of the OECD, which is a division of the World Health Organization, and that particularly look at essential medicine. It became very tough when he finally gave his acceptance to come for the conference. I was exceedingly happy. More importantly, that the FIP president has also personally written to pay us a visit to Nigeria. Unfortunately, the COVID saga broke out, and it became difficult to track down Frederico. Not only until about a week ago was when I had to get my peace, when he finally reverted to me and said, Samuel, sorry, now the second wave of COVID in Europe has almost swallowed them. And because of that, he cannot come, for one, but he will be glad to send his representative, send his speech, send his presentation. And we have to interface with the WHO office in Nigeria and got one of the technical officers in that organization to present on his behalf. And that's why I want to introduce to you one of our own two pharmacies, Hamsat Omotayo, popularly called the Big T. That's the Big T of the Great Ife. I want to also let this gathering know that Pharmacist Omotayo is another very passionate pharmacist. In the house, I cannot but also recognize a very special person. He's a geriatric pharmacist. And when it comes to partners' activities, Pharmacist Kilani, I hope he's still in the house. He had a meeting that he's supposed to be attending by 11. He's been with us. Pharmacist Kilani, please. You stay in the house? Can you stand to take a bow? Has he stepped out? All right. He will be having a session with us tomorrow. They are formally invited for tomorrow's session as panelists. So, I don't want to take too much of your time. Colleague, my message is simple. We are in the time of disruptive innovation. We have to do things differently because we cannot continue to do things the same way and we expect a different result. And for the promise that we gave you when we seek this mandate, we told you we're going to change the narrative of community pharmacy in Nigeria. And I'm happy that we are receiving support, particularly of the National Executive Council of Acpn. All of these things we are doing, they have backed us up. They have been our encouragement. I want the audience to clap for my NEC members, particularly for those who are in the House and the National Executive Committee. This conference, as we all know, it is going to be addressing, optimizing primary health care delivery services in Nigeria, the untapped potentials of the community pharmacies, which we all know. And the message is this, that if developed climes, the Europe, the Americans, are taking maximum benefit of the community pharmacies, one, because of the accessibility, because of the trust, because of the knowledge and capacity, why should our own clime, that we are even less developed in terms of our health system, should not take this maximum advantage? And more importantly, because today, WHO is in the forefront of this advocacy world over. And I'm happy that we have received an assurances of the country representative of WHO to share the section we're going to be having tomorrow, where we're going to be making statements, particularly on our commitment to deliver primary care in Nigeria. And one unique thing that's going to take place in this conference, which we are going to be telling you sooner than later, is the signing of Abuja Declaration, which is going to be the third of such in the world, and that is unique to us. The first was done in Astana by May last year, and the second was signed, the same declaration was signed at Ankara, October last year. The president of FIP had agreed and has given us the go-ahead to sign this same declaration, which is a declaration that was written and FIP on community pharmacies' commitment to deliver primary care. I'm assuring you, by the grace of God, we are going to sign the same declaration here live tomorrow under the supervision of the country director of WHO. So I want to congratulate you, and you will prepare for this very important section. On this note, I want to welcome everyone to this conference and assure you that, just as was announced to you, this is just a symposium. We are set for a great time in the evening. Deliberately, we put the opening ceremony for evening. And what that simply means that we want you to come relaxed. And I can inform you, like I did inform to our people yesterday that come for the work, our guest The chief among them are already in town. I'm glad to inform you, announce to you that the government of Ondo State is fully in Abuja to support the conference, the opening ceremony, to grace the opening ceremony. The governor with his cabinet will be here. The NEC has approved an award for the governor of Ondo State, the former governors of Kano, Senator Kwankwaso, and the host of them, and 2 senators. And all of them will be here in the afternoon by 3 p.m. So I encourage you to please come in good time, come prepared. Though there are certain things I'm seeing now that I didn't want to, I naturally wouldn't want to see now, but I still want to allow them. And that is to say, this morning, like I did announce to us, supposed to be a formal event, and I expect you to be corporately dressed. But in the evening, I'm expecting you to come with your regalias. I want to see a lot of flowing agbadas and flowing traditional regalia. It is an opening ceremony. It is a ceremony by excellence, after which we're going to have photographic panorama. So I want to, on this note, I want to welcome you to a conference of a very unique experience, and I promise you that with the grace, by the grace of God, we will not disappoint you that you have come to Abuja. Thank you very much.
Thank you very much, the chairman himself. We also want to use this opportunity to recognize the fellow of the Pharmaceutical Society of Nigeria, or the fellow in the house. We know you people are many here. We welcome you, we respect you, and of course, we appreciate your presence for this symposium. Quickly, just a recap of what the chairman has said. We are here today, this morning, talking about the untapped potentials of the community pharmacist. When we're talking about the potential of the community pharmacist, we are looking at a well-defined services and roles that are to be played by the community pharmacist, especially in line with the current global health practices. These untapped potential should also come with accrued remuneration for the service being provided. These are some of the topical issues we will be engaging as our speakers shall be providing for us. So Rebecca, don't you think we are in for a nice time this morning?
I'm excited already. And like the chairman has rightly said, every event during this conference, starting with this symposium, promises to be very highly informative, highly educating, and I'm very sure that, like he rightly mentioned, we're not going back the same way we came. So we're going back as better, well-informed pharmacists that are ready to practice like persons ahead of time. Let's celebrate ourselves. I think the CPC, the NEC, everyone has done beautifully well to put together this beautiful event.
Thank you very much. Quickly, we want to believe the representative of Society for Family Health, SFH, are ready for the presentation.
SFH, can we have you now? If you're not ready, I would want to straight away introduce the representative of the registrar, Pharmaceutical Council of Nigeria. He has been introduced by the chairman already, but I would love to introduce him again. I'm talking about the Director, Planning, Research and Statistics, PCN, our own pharmacist, Ibrahim Babasheu Ahmed. He's a fellow of the Pharmaceutical Society of Nigeria. Thank you very much for coming. We're glad to have you here. SFH, you have 10 minutes. Can we have you now?
contraceptive option with DMPASC. Basically, I believe we all know Society for Family Health, and I'm happy to be here in this Acpn conference. Let me just give us a brief introduction of who we are. Society for Family Health is a non-governmental organization that was incorporated in 1985. We work with both private and public sector using social marketing strategy to improve access to essential health care information, services, products, so as to motivate adoption for healthy living. I have just 10 minutes, so I will just quickly run through what I have to present. Now, I just want to take a health index in Nigeria. In Nigeria, we noticed that the maternal mortality rate is about, for every 100,000 live births, 804 women die. And that is a call for concern for us as health provider. This was taken from WHO documents 2015. And so for that, instead of us to fold our hands as health provider, we need to work hard. We need to encourage and then teach people that are not aware of family planning. I know as pharmacists, we are not so conversant with family planning, but I want to encourage, I love reproductive health, so I want to encourage us to start that aspect because it's very important. People in the rural areas, some of them are dying because of this. Having seen that, how can we prevent this maternal mortality rate? One of the ways we can prevent this maternal mortality rate is by contraceptive option, family planning. And then when we do that, we can prevent unsafe abortion. We can avert a lot of things that takes place among women, young teenagers. We can avert such. I'll be very, very brief in my presentation. Having said that, the need for family planning, we discovered that we have 16% unmet need for family planning. That 16% unmet need is very, 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 very huge. And as a matter of urgency, we need to put in our best to see what we can achieve. From the urban region, we have 14.9%, and then the rural area, we have 16.8%. Now, look at the map here. Using the map of Nigeria, we just want to use an analogy here. We have the northeast, we have the northwest, we have the north central, we have the southwest, and then we have south-south, and then the southeast. If you look at it, the percentage is more around the northern parts of Nigeria. That is, they are not aware of family planning. That shows that we health providers, we need to put in more effort. Because I believe, being a pharmacist, everybody look up to you. Before they go to a doctor, most times, they come to the community pharmacy. When you see somebody, any little thing, the first thing they think of, let's go to this pharmacy. Let's go to this pharmacy, we'll get results from there, especially when the pharmacist is really equipped. And so you see people rushing to that place more than hospital. And so that is why we need to really grow in this aspect of reproductive health. Having seen that, for Nigeria governments, they have their own plan. They want to see that by the end of 2020, which we are about ending, that they address the unmet need of family planning, and then this unmet need is to increase access to choice and also to expand access to it. People in the rural area that you cannot reach. Sometimes they don't even have a pharmacy there. They just have a CHU, a PMS there. And they call that person doctor, and they call that person pharmacy. And so that's the plan for Nigeria government. Now, I want to introduce one of our products from the injectable family planning contraceptive, the depot metroxyprogesterone acetate, also known as Cyanapres, DMPASC. I believe as community pharmacists, we have been coming across this Cyanapres. We have held workshops in our location because we have reps in different locations. And these reps, they are trying to do some providers training. And so if you have any question, you can always reach out to us. This is a self-injection contraceptive. What is Cyanapres? Cyanapres is depot metroxyprogesterone acetate, and then it's also called, it's a subcute SC. And the Cyanapres is registered with the trade name by Pfizer. And then Cyanapres contains 104 per 0.65 milligram of depot metroxyprogesterone acetate. Cyanopress protect against pregnancy. And how does cyanopress, the mechanism of action of cyanopress? It prevents the egg from being released from the ovary. We know that this family planning injectables have about 3 ways of inhibiting pregnancy, and therefore interfacing with the existing, they does not interfere with the existing pregnancy. So by the time it prevents the release the egg from the ovary, there's no way pregnancy can take place. Now, this is just a brief summary of the mode of actions. It inhibits the secretion of gonadotrophic hormone. It in turn prevents follicular maturation and ovulation. This results in endometrial thinning. When the endometrium is very thin, there is no way implantation can take place there. It also causes the thickening of the cervical mucus. When the cervical mucus is very thick, the sperm will not be able to swim. And therefore, the strength, how effective the sperm is, determine how fertility can occur. So we know that these are factors. When you have a low sperm count, when they say somebody have a low sperm count, a patient come in, the sperm is not active, and so fertility will be low. And so these are the mode of actions for these injectables. Now, efficacy of cyanopress, it is efficacy. It is the most effective at most 12 to 13 weeks. That's for 3 months. It's a 3-month injection. And then it can be later than 14 months. It's okay, past. But at least the injection should not be more than 14 weeks. And then the injection provides immediate contraceptive coverage. Some of the contraceptive we have, like the implant, when you take it, you have to wait for about 1 week before the effectiveness starts. So, but this, immediately that injection is injected, the action takes place immediately. You don't need to wait for like a week. Having seen that, what are the side effects of cyanopress? We'll not just come here and tell you this is good, this is good, this is good. For every good thing, we know the bad side of it. Even paracetamol. When you take paracetamol, you take it excess, you know the side effect. Even food and water. We know that when you take water excess, sometimes it becomes, your body system becomes uncomfortable with it. So we have the major and the less side effect for this contraceptive cyanopress. Irregular menstrual bleeding or spotting, weight change, that's gain or loss. Some patients can gain weight, while others can lose weight, depending on their physiological nature. And also headache, we have dizziness, we have abdominal pain, we have nausea. And then the less side effect, we have abdominal distension, change in mood, and sexual drives. So most times, when women are on contraception, the rate of sexual drives reduce. But sometimes, we don't usually explain it to our patients. So as community pharmacists, as the first doctor that patient gets to meet each time they have issue, it's good for us to equip ourselves on the major thing. We call these kind of things like this self-care. Little things, when you talk to them, it's more than giving them drugs, and they will look at you more than any other person like God. Now, having seen that, we have different sites for this injection. It's very simple. I know sometimes they'll tell us that we are not supposed to inject as pharmacists, but this is self-care injection that you can teach your patients. They will go home and do it. From the slide here, you can see the location where you can inject the thigh, number 1, number 2, number 3, number 4, number 5, number 6. The thing is that after an injection on a particular side, you should not repeat it again. That's the next 3 months. When you inject at the lab here, it shouldn't be re-injected at the same spot. You should do it on the other side of the lab. So when you do injection at number 1, the next 3 months, you should not inject at number 1 again. You should inject at number 2. When you inject at number 3, the next 3 months, you should inject at number 4. When you inject at number 5, you inject at number 6. I'll be very brief. My time is very short. Who can use cyanopress? Who want effective, reversible method of family planning contraception? You can use the method. Who are postpartum and not breastfeeding? The method is also good for them. And also, who have, after post-abortion, you can recommend the method for them immediately. And then smokers of all ages. There are some contraceptives that are not advisable for smokers. And then who do not mind irregular bleeding, amenorrhea. The side effect of it is spotting. So when you have patients, I want to say this, when you place a patient on this Synapres, sometimes they will come to you with spotting, bleeding. This spotting bleeding that is always coming up. They'll be like, I'm tired of it. What's the point of this method? But I want to advise that you have to encourage them. It's hormone. It takes time for the body to adjust to the hormone in our system. And so because the configuration, as pharmacists, we know it in PharmChem, that once the chain a structure is changed, it takes time for it to come back again. And then you encourage them not to give up, not to be afraid about it. So over time, it will be better. Usually, medically, not really documented. In practice, there are methods they use in stabilizing such patients. Having seen that, who should not use Synapres? Women who are already pregnant. If you are pregnant, use the method, your pregnancy remains. It doesn't cause abortion. Who have hypertension, who have had heart attack, stroke, irregular, or have developed migraine, they should not use it. Then experience undiagnosed vaginal bleeding. One of the side effects is spotting and bleeding. So when you have undiagnosed vaginal bleeding, and then you are on Synapres, you are complicating the issue. Who have severe liver disease, uncontrolled diabetes, and lupus. Who have suspected breast cancer. And also are breastfeeding a baby that is younger than 6 months. Usually contraceptives start from 6 months. After 6 weeks of childbirth, you can go on contraceptive. Want to compare the magic of this family planning here? You can see that it's a three pre-filled syringe. You don't need to get a syringe to use for this. I want to show you as I'm talking so that we'll understand it better, because it's a new technology of injectable contraceptive. You don't need to buy a syringe. It comes in a pre-filled syringe. The drug is inside. 2 ml syringe is there. So it's a subcutaneous method of injectable contraceptive. So, and it's given under the skin. And also, the dose has lower dose than depo-metrozole progesterone acetate IM. That's Depo-Provera. This is the same thing with Depo-Provera. The difference is the method of injection. This is subcutaneous. Depo-Provera is IM. And also, we're comparing this with Depo-Provera. And also, the syringe here is 2 to 5 centimeter needle. That's how it comes. And then comes in Depo-Provera comes in the vial. You need to mix. You need to get a syringe. So the process is cumbersome, but this, you just take it. You just take it, and then you shake very well, and then inject, and that's all. It doesn't cause death all over. That's the benefit of this. And the strength of Depo-Provera is 150, while this is 106 milligram per 0.6 Now, and the diameter of Depo-Provera is 3 to 8 centimeter. Now, I want to compare the similarity between this and Depo-Provera. It's safe and highly effective. It's very, very safe and highly effective at preventing unintended pregnancy. And also, it delivers at every 3 months. Every 3 months, that's when 12 to 13 weeks. And then it does not protect against HIV. So if you are on this method and you want to take precaution for HIV, you need to use condom. It's condom you use for that. You don't use this for prevention of HIV. And also, they have comparable side effects because their active ingredient is the same. So they'll have comparable side effects. And then stable at room temperature. The good thing about this is that you don't need to put it in the fridge. There's no recommended just room temperature. It must not be a cold temperature. You can take it from here to Sokoto, which is the hottest part of Nigeria. You can take it from here to Jos, which is the coldest part. Another part of the world, or Nigeria, you can take it. People in the remote area that don't have lights, they can use it and put it in their box. And that's why it's good. So if a patient is aware of this, a client is aware of this method, he or she can buy like 3 or 4 of this syringe for the whole year and put in her box. And then every 12 to 13 weeks, she will be using it. It's a self-inject. We would like to play a video after the meeting if we have the time. Return to fertility is, it takes about 4 months to 1 year. So we'll be truthful to ourselves. We'll not tell you it's immediate. It takes 4 to 1 year for return to fertility to take place. And then, depending on how long you have been using this, the return to fertility depends on how long an individual have been using the method. And that is it. Having seen that, the status of DMPS in Nigeria, it was approved in Nigeria. That's Press 2017. And then was it's registered for self-injection. And that is why we encourage self-injection. When we come to you, we tell you to train your clients when they come. Train your client, teach them what to do at each time, how to inject themselves. It will less burden on you. You have time for other things, for other patients. So when they know it, it will be better for them. Even in the remote area, they can use it. And then in September 2018, Nigeria Essential Drug List, it was enlisted. They approved it there. And also, the Federal Ministry of Health has fully scaled up the DMPSC across all 36 states, including FCT. I think every primary health care general hospital, they have this now. Because even FOMLH, they are already advocating for this Press. Having seen that, some countries, there's a experience from other countries that I want to share with you. In Malawi, Uganda, and Senegal, they discovered that high continuation among women with self-injection. Do you know the reason? Relative to those who go to the facility for them to inject them. Because of it's convenient. They don't need to go travel a long distance, very convenient. And then you do it yourself. If you don't want anybody to know what you're on, you can hide it. And also, there's evidence that they prefer this than Depo-Provera. They prefer this because when you are on, like some community, they don't want their husband to know that they are on family planning. They do it on their own. Self-injection is acceptable for most women. I want to just thank you very much. Thank you very much. We are sorry, we have a video. Okay, thank you very much.
Thank you very much, Society for Family Health. If you have further questions or inquiry, please meet up with them and they would answer every question we have. Let's put our hands together for them once again.
Thank you very much. We are going to the main reason why we are here this morning. Why we be inviting the chairman for the symposium. Let me quickly paint a scenario. During the heat of the COVID-19 pandemic, I'm talking about March, etc., we have a lot of patients trooping into the pharmacy and community pharmacy to be precise, asking for hydroxychloroquine, asking for this, etc., etc. It was the only pharmacist, in fact, at that time, the wearing of masks as one of the preventive measures have not been well established. It was the community pharmacist, you, myself, were the one that stood to save the nations at that time. And if I may also recall, in the United Kingdom, when this same scenario happened there, one of the key health professionals that the Prime Minister, talking about Prime Minister Boris Johnson, single-handedly praised was the pharmacist. In fact, it's of record that the Prime Minister earmarked £300 million to cushion the effects for the community pharmacists in UK. Here in Nigeria, the government here marked 100 billion naira for the healthcare to cushion the effects. I don't think any community pharmacists have had access to that. When we're talking about untapped potentials of community pharmacy, like I said the other time, we are looking at the properly defining the roles and services, and of course the accrued remuneration to this. And that is why we are here this morning. We are going to the symposium. We are still reaching you live and direct from the International Conference Center. Rebecca, you want to invite the chairman?
Before I invite the chairman, I can see there's so much emphasis on the accrued remuneration. I hope that the chairman has heard that, so he's going to do justice to that while we sit back, relax, and get educated. Without wasting our time, I'm inviting the chairman of the symposium to give us an introductory speech, tell us why we're here, what we're here to learn. No other person than our own honorable pharmacist, John Enger, a fellow of the Pharmaceutical Society of Nigeria. Ladies and gentlemen, let's put our hands together for pharmacist John Enger. He's the chairman, Hospital Management Board, Benue State. He'll be giving the introductory speech for this symposium. Thank you very much, sir. You're welcome.
Thank you, MCs. The National Chair, Acpn, members of the ESCO of Acpn, members of Board of Trustees of Acpn, the guest speaker of this occasion, I'm standing on the foot of the chairman, so I will come to that. The guest speaker of this occasion, Mr. Federico Gonaz, who is represented by pharmacist Hamza Taiwo. Other panelists that are here, Ms. Anne Patterson, who is the mission director of USAID, and everything is led by my brother, pharmacist Emmanuel Guche, the representative of the double prophet, Elijah Mohammed, our PCN registrar, pharmacist Baba Shehu, the representative of the Honorable Member, House Committee on Primary Health Care Services, who is Dr. Shehu Barebe Shuni, and is presented by our own pharmacist Abubakar Umar. Fellows of PSN, fellows of Postgraduate College of Pharmacy, dear colleagues, ladies and gentlemen, we are here on a very important mission, the symposium, and the topic is the strategic potentials of community pharmacists in primary health care services delivery for the attainment of universal health coverage. It's not gainsaying how important this topic is to us, but we are to note that primary health care refers to essential care that is based on scientifically sound and socially accepted methods and technology. That's the very simple definition of primary health care. And when we talk of pharmacists, I think the definition just captures it all. And when we talk about universal health coverage, you are talking of a health system which all residents of that country or that region have access to health care. So involvement of pharmacists or community pharmacists for that matter in healthcare captures it all. So you are there to optimize, to attend the healthcare that we need. I think the topic has came at the right time. But we have people that we know can bring this to bear. The chairman of National Primary Health Care Development Agency, who is unavailable absent. It's not here, I'm not representing him per se because I have no communication, but I'm standing in for him. He can call me anytime. But we do know that in Nigeria, after the Alma Mater Declaration of 1978 and the introduction of primary health care in Nigeria, the Primary Health Care Development Agency was created in 1992. It was when it was merged with the essential, that is what we call immunization, in 2007, that it took care of everything that we do need to know in terms of healthcare at the primary care level. Normally in Nigeria, we take the primary health care to be the one that was manned by local governments before. But now, most states have given the primary health care, have created primary health care development board, in which case they are now the coordinating units of the primary health care in each state, headed by or coordinated by the National Primary Health Care Board. We are here with these distinguished gentlemen who, if you listen attentively, will give you what you need to know. And we are not going to leave here empty-headed. I think we'll be stuck with the knowledge we need to know. And we are sure that after this, as the chairman did inform us, when we are signing this communique, as he said, tomorrow, as he said, we're not just signing to be part of it. We are signing because we have been part of it, but not official. Pharmacists, community pharmacists, for instance, or in particular, have been part of the primary health care in whatever they were doing. And so, without wasting much time, we'll call on the guest speaker who will come and give you what you need to know about the pharmacist's involvement, particularly the role that we have to play. If we believe that primary health care have to do with scientifically accepted and socially accepted norms, we are there. Pharmacists are there. Maybe I'm biased because I'm a pharmacist, but you should know that we need to emphasize that. Thank you very much. And I pray that you listen attentively to this discussion because the symposium is very important. The MC, I think you will join me here because the guest speaker will have to be called to now kick the ball rolling properly. Thank you.
Thank you very much, Honorable Pharmacist John Enger. I think he deserves more accolades, so let's put our hands together for him. Thank you very much, sir. Okay, so I'm standing on his protocol, so I have the privilege and the right to invite the speaker, Pharmacist Hamzat Omotayo, the National Professional Officer, Essential Drugs and Medicine. Please let's put our hands together for him as he comes upstage.
Pharmacist Omotayo Hamzat is representing the keynote speaker for this symposium, talking about Mr. Frederico Guanas. He is the deputy head of Health Division of Organization for Economic Cooperation and Development, PARI. Omotayo.
Pharmaceutical Society of Nigeria. Members of the Pharmaceutical Society of Nigeria, members of the Association of Community Pharmacists of Nigeria, invited guests. I'm happy to join you this today to celebrate our profession. And I'm also happy because what I can say that we have started talking. Before, all the things we do is murmuring to ourselves. Now, taking this out, and I hope this will not be another conference that will be forgotten by January 2021. I hope we'll be able to take actions beyond this all. And before I start, I want to ask, what is the most important thing that the lady from SFH talked about their product? To me, it is that she goes to pharmacies and asks them, this is my product, please train your patient on how to use it. And that is one of the services that we render and we don't account for. I hope we appreciate this. You train the patient, you follow up with the patient, and nobody pays for that. Leave payments apart. Nobody recognizes that you are doing anything. So when the national chairman approached me and was talking about the challenge with my colleague from the European country, regional office, I agreed to do this. And Frederico was very kind enough to share his presentation, which he made in Ankara, which he made in Amman. And I told Chairman, that is the problem when we import technologies that are not adapted to us. At the European level, they are not talking about inputs. It is a given that the government will allocate enough resources to health. They are talking about the outcome and the impact level. We are still talking about input. So I will domesticate this to what looks like Nigeria. And so I did some modifications. So this morning, you'll be seeing a mixture, rice and beans. This will be the outline of the presentation. We'll go through the history, introduction, talk about universal health coverage. Thank God the chairman has actually mentioned and defined it, so I won't be spending much time. We'll discuss whether the PHC we are talking of is actually, have we fully realized it? Even in the developed countries like the OECD, we'll talk about what pharmacists can bring to the table. Talk about some innovations. How can we make the change? And discuss briefly on the legal and regulatory framework for community pharmacists. Actually, primary health care started before 1978, the Alma Ata Declaration. But that was when officially countries, governments came together and formally said, yes, we recognize that this is the way to go, and made those declarations. So, and governments all over the world and WHO came together, committed to accept primary health care as their national policy. In fact, the full thing, the real thing is primary care. Because at times when we say PHC, we think about that structures all around our local government. In some places, no staff to man it. In some, the community health extension worker. In some, you see nurses, and in very few places, you see full complement of the staff that are required. And that is why evidence suggests that there's need to understand that PHC is a process in the framework of complex intervention that consider not only outcomes or impact, but also why and how an intervention works and does not work. So it's not just about that structure. There are so many things that comes together to form the primary health care. If we talk about primary health care, we still think at times in our subconscious that it's just about government providing that care. It is more of government facilitating the provision of the care. And if we understand it from this perspective, we'll get on much as we go along. After the 1978 declaration, African countries came together and we had the Bamako Initiative in 1987. And it also talks about the same primary health care. The focus was, but that Bamako Initiative particularly aimed to increase access to primary health care by raising the effectiveness, efficiency, financial viability, and equity of health services. So this again talks that this is beyond that structure, but it's a whole process that involves multiple stakeholders. And if we don't understand it very well, we will focus and think we can just do it through government interventions alone. And in Nigeria, between 1975 to 1980, health system development was initiated with PHC as the cornerstone. Then we have the National Basic Health Services Scheme, NBHSS, which was developed with PHC as an approach. And during the tenure of Professor Oluko Yerabson-Kiti, he started by adopting, as the Minister of Health, he started by adopting 52 PHC in local government areas as model, and he was following the Alma-Ata Declaration. Then the first comprehensive health policy based on PHC was launched in 1988. From 1986 to 1990, Professor Oluko expanded PHC to all local governments. He achieved universal child immunization of over 80% and devolved responsibility for PHC to local government areas. Please mind that we moved it to the local government area, which is the natural thing to do, because that is closest to the people. But perhaps that is where the problem lies with the system we run in governance now. Nigeria continued to implement PHC policy based on Alma-Ata Declaration for the benefit of the Nigerian population and continue with emphasis on prevention. Then there was the creation of MPACD in 1992. It was merged with National Program on Immunization in 2007. And the main focus, the agenda, the mandate of the MPACD has 7 corporate goals, which are control preventive diseases, improve access to basic health services, improve quality of care, strengthen the institution, develop high-performing health workforce, strengthening partnership, strengthening community engagement. I want us to focus more on the last 2, strengthening partnership and strengthening community engagement. because that is where our services as pharmacists will come in. We need to partner, or our government needs to partner with us to improve coverage of health statistics, and we will see where we are in the country and why we need to do this. And because we lived in the community, we serve members of our community, immediate community. In fact, you can call it neighborhood. This becomes very important. But 40 years after Alma-Ata Declaration, we have the Astana Declaration in 2018, October 25th and 26th. There was a global conference on primary health care, which the team was from Alma-Ata towards universal health coverage and the sustainable development goals. It was held in Astana in Kazakhstan. And the government at the end of those 2 days, present, declared that we heads of states and government, ministers and representatives of states and government participating in this conference reaffirms the commitment expressed in the ambitious and visionary declaration of Alma-Ata of 1978 and the 2030 Agenda for Sustainable Development Goals. In pursuit of health for all, they hereby make the following declarations. But this statement, I read it because it still underscores the fact that despite the gains between 1978 and 2018 rather, 40 years difference, there are still gaps, and we did not complete the agenda of the Alma-Ata Declaration, and that it is still relevant that the primary health care should be the focus. But this time around, before they went ahead to make the declaration, they put some things that they envisioned. And there are 4 of them. That government and societies that prioritize, promote, protect health and well-being at both population and individual levels through strong health systems. They also envision that primary health care and health services that are of high quality, safe, comprehensive, integrated, accessible, available, and affordable for everyone and everywhere, provided with compassion, respect, and dignity by health professionals who are well-trained, skilled, motivated, and committed. And I dare say, even more boldly, that this is what pharmacists represent in our practice. They also envision that enabling an health-conducive environment which individuals and communities are empowered and engaged in maintaining and enhancing their health and well-being. And finally, that partners and stakeholders are aligned in providing effective support to national health policies, strategies, and plans. The National Strategic Health Development Plan 2 is our National Strategic Health Plan that we have, 2018 and 2020, recognizes the contributions of the private sector. What I am not sure very well is if community pharmacists are contributing or are acknowledged with their contributions. Is it documented what we have done in this country? Are we involved in the policy dimensions, the policy creations, the dynamism of policy that changes in this country every 3, 4, 5 years? Are we involved in the coalition amongst private sector, that supports the government? If we do, are these attributed to us? I'm raising that so that both at the Acpn and PSN level, we need to raise it into our consciousness that we need to be involved in policy making, in policy creation, and agenda setting for it. Then they went ahead to make 3 declarations. If you go through them, I'm not going to read them. They are just saying the same thing that Alma-Ata Declaration said in different ways, and now bringing in the universal health coverage and sustainable development goals. Particularly the sustainable development goals 3 and 3.8. But they went ahead to affirm and to declare that they find it ethically, politically, socially, economically unacceptable that inequity in health and disparity in health outcomes still persist. And committed to 2 things: that they are going to be making bold political choices for health across all sectors, and they are going to build sustainable primary health care. We mentioned the universal health coverage, which is all about what the chairman has defined, and I promise I'm not going to go into details of it. Ensuring all people have access to needed key promotive, preventive, curative, and rehabilitative health services of good quality at an affordable cost without the risk of financial hardship linked to paying for care. We provide most of these services in our community pharmacies. But how is health financing in the country affecting the provision of that services? How many times in our pharmacies somebody has come in with a prescription and we say, this is the cost, excluding our professional services, excluding the cost of our consultation, and the patient turns away and says, Madam, what is it? I will come back. The major reason is because they cannot pay. Out-of-pocket expenditure in the country has been documented to be as high as 72%, which is affecting us also because we need to provide quality services, quality medicines, and yet they are unaffordable to the client. Whereas there's National Health Insurance Scheme that we are supposed to be involved in to be able to provide these services. That is another discussion for another day. But that is not encouraging pharmacies to provide these services. And we go long way in pain to ensure that we still assist our clients who are Nigerians, who have rights, like Alma-Ata declared in the first instance, that the PSC, that health is beyond the physical structure. It is beyond doctors. It is beyond the nurses. But that if I don't even have funding to procure this, I have a challenge. That there are other stakeholders who may be able to provide this effectively and cost-effectively, and cost-effective in that wise, but yet are not being attributed or are not being considered for out-of-the-box creation. That even when we have these PACs, there are barriers which can limit your access to these PACs. Either it is 3 to 5 kilometers, 10 kilometers away, even when a mother is in labor pains, you still have to find keke napep to drive her. And if it is the day that you cannot find one, there is a challenge. Or a baby convulses in the evening, and the next PSC is like 10 kilometers away to me. But there's that professional in the neighborhood who they will go and knock on his door at 9 p.m., 10 p.m., and will quickly provide the first aid, pending when he refers for them to go and assess it. And at times, manages the elderly in the neighborhood, ensure that they are well catered for when they don't even have the funding to assess it. And this is the thing that the universal health coverage, SDG 3, is talking about. And you will agree with me that pharmacists, community pharmacists in particular, perfectly fits into a role in this, supporting the attainment of universal health coverage. We need to formalize that contribution. From Alma Ata to Astana to SDG to universal health coverage, it's still saying one thing. Primary care is more important than ever, simply because the cost of health care continue to rise. And as such, countries will do better if primary health care are taken up, because they are more preventive and they prevent that catastrophic expenditure in the long run. They can easily, as part of their work, consider promotive and preventive services. And that people expect more from the health system because population are getting older. There are more chronic diseases. In fact, there are more pandemics, breakouts of diseases. But people are better educated and informed these days. You know what? Google is their friend. They have headache, she Googles it. I have headache in the right side of my head. Google doctor gives the answers. What is the possible thing? So when they are approaching the health professional, they are talking from the standpoint of somebody who have received some information, no matter what the quality of it, whether it is right or wrong. But he is challenging, ready to challenge you. Doctor, you said this, but I read here. And as such, this requires that the professional that will be attending to people have to be skilled, well-trained, and educated, and should possess multiple skills, including psychosocial counseling, to support the patient. And I make bold again to say that this is what members of Acpn across the country are providing. The potential for primary health care is very, very huge. If that primary health care is strong, it can contain the rate of growth in health expenditures and improving health system efficiencies. That is, if diseases are detected, treated, or referred promptly by a professional. It improves population health outcomes and health system responsiveness. If you put it together, if it's identified at the primary health care level, either in the PSC as an institution or in a community pharmacy, and is treated, that saves cost. Or if it is not being able to be treated finally, provided for in first aid, and referred promptly. and also addresses the problem of inequity that the government in Astana Declaration affirms that it is unacceptable to them, both socially, politically, and otherwise. A strong primary health care is people and community oriented. It is continuous because services should be available continuously. And that is why it is normally located in the community, close to people. It should be comprehensive and well coordinated. And for all this, the community pharmacies are located in the community, inside the neighborhood. In fact, most of the time in remote areas, they participate in community engagement. When there is a naming ceremony, the pharmacist in that community pharmacy is the only one in the village. He is involved. So it's able and better placed to advise the mother. You know, you have to get immunization. And just imagine if that pharmacy can provide immunization services. That makes it easier for the mom. She doesn't have to travel 10 kilometers to the nearest PHC to get immunization services. But yet, what we have is not strong, even in the developed world. So this is coming from Federico, that even in Europe, that they do not talk about input. They talk about how well, what is the output, what is the impact of what they are doing. They still identify gaps in the PHCs that we have now. And this graph is talking about sheer potential of affordable hospital admission due to 5 chronic conditions as a percentage of the total bed space. That they do see that there are some avoidable hospitalization. If the PHC has provided, at that level, primary care has been provided, it wouldn't have led to hospitalization. And because it has led to hospitalization, it is an additional cost to the healthcare system. And that some patients, even in their system, are not receiving recommended care. Chronic patients, people with hypertension, diabetes, are not receiving recommended care in the past 12 months. This was done in 2014. So if this is what is happening there, what is it that is happening in our home clime? Those are the places we look at that they have standardized operation, they have standardized process. They are primary health care, both private sector, government sector, is well organized. They still identify these gaps. And you see, when I first saw this heading, what they are talking about is that they are not receiving preventive tests. They are not talking about the treatment, that preventive tests, they are not receiving it. What is happening in our own clime is a far cry from this. People are not even receiving the treatment when they are down with the diseases. And in Africa, our problem is that governments are not putting much into the health system, and that people are paying above 20% from their pocket as out-of-pocket expenditure. And my dear country tops the chart. We are above 70, between 72 and 75%. If Nigerians are paid out of pocket expenditure. That means they come to the pharmacy, they pay the money, there's no reimbursement from any place, and if they don't have the money, either the family sells their property or community comes together, friends and co-workers, to pay for them. And our performance on key UAC indicator has not been very optimal. We talk about antenatal care coverage over the last 10 years. We talk about proportion of birth assisted by skilled birth attendants, childhood mortality rates, death per 1,000 live births. You see as high as one for under 5 mortality, as high as 157 per 1,000 live births. Maternal mortality ratio as high in 2013 as 576, and it came down a bit in 2018 in, how many minutes do I have? 5 minutes, okay. As low as 512. This is just to talk to us that even with the gains that we have identified, our input into the health system is not enough. And that way, the only way we can leverage is about bringing in public-private partnership, the private sector to support. Key members of the private sector in terms of health is the community health, community pharmacists who are in the neighborhood providing services that can help our health indices. Even if it is to identify that a woman is in labor and will need certain services and promptly informing the husband, supporting the husband to go, or giving immunization services, or monitoring the blood pressure and providing services to maintain that blood pressure, or to refill prescription when they have been obtained from other levels of care. And these services should be attributed to. I don't want to use the word of accrued remuneration, and that's what I'm using, attribution. What pharmacists and their pharmacists can bring to the table. Professionalism, pharmacy practice pharmacy is a trusted profession, and there are studies that have documented this. They are very close to their community. Accessibility is 24/7. We have pharmacies that do 24 hours shift, and it is not the fact that when I get there, they are closed. Broad competencies and skills, they provide drug information service, and most of the time they offer this as a complementary service. The American Society of Health System Pharmacists listed about 10 roles the pharmacist can play in primary health care. And that involves performing patient assessment for medication-related factors, other laboratory tests, initiate or modify medication therapy care, provide information, education, and counseling to patients and to other health care workers, document the care provided, identify any barriers to patient compliance, participate in multidisciplinary reviews of patient progress, communicate with payers to resolve issues that may impede access to medication therapies, communicate relevant issues to physicians and other team members. Some promising innovations with community pharmacists around the world. And I just listed, we can check this up, what pharmacists are doing around the world. And this is not strange. It's not that we have not done anything in Nigeria. In the GALE project, the pharmaceutical services worked with community pharmacies, and we saw improvement in people coming to take their refills from ARV. And that project concluded that the centralization of HIV-related services to community pharmacy will actually lead to sustainability of the care itself. Because you find that most of the patients that were devolved down to the community pharmacies find it easier to go and take their refill instead of traveling every week or every month to far places where they can access secondary health care facilities. They get their drug and they get their prescription and they pick their drugs, counseling from the community pharmacy very close to them. This was also done in an initiative by USAID, which they tag leveraging private pharmacies to expand ART distribution, promote adherence, and mobilize resources. I'm sure my brother will talk more about that. We have also seen the roles of pharmacists in Ebola and COVID-19 pandemic. These are well documented. So it is not that we are talking about things that are rocket sciences that have not been done. All over the world, we have this. And there are 20 countries where pharmacists administer vaccines. I've put the reference there, we can check it out. But out of these 20 countries, we have Argentina, Bolivia, Democratic Republic of Congo, Canada, UK, US, Australia, Costa Rica, we have South Africa. So they are not out of this world. Even in Africa, we have countries where pharmacists administer vaccines. It is stored with them. One, the system is assured of the fact that that professional will maintain the integrity of the vaccines. We do not have to be carrying code boxes about to distribute polio vaccines. People can actually walk into their community pharmacy very close to them and get there. In fact, the pharmacist can do it as a service, even when it is remunerated, to go into his neighborhood and ensure all, because he's part of that neighborhood, all children that are below the age of, below certain age are given polio vaccines. They are given, when they have a naming ceremony, he's following up with the mother after 1 week that you need to get the vaccination for your child. Making the change happen, what do we need to do? There's need for the organizational change and regulatory changes. I am not going to spend more time on this. We need to do new configuration. We need to, for care delivery, we need to bring that, leave that thinking of it has to be in the confines of a structure called PAC. Primary care can actually be delivered from a community pharmacist and from other mechanisms, which when you think out of the box. We need to, into our curriculum, put this in part of the curriculum and the training of our professionals. And the use of digital technology, telepharmacy, telemedicines will come into play. Economic incentives, that is where my MC will be very happy to listen to. Making general practice more attractive, making it more attractive, particularly to community pharmacists. Paying for prevention. I go on preventive campaign. This is a service to the community that should be monitored, and we'll talk about that briefly. Patient engagement and information, systematic use of patient-reported measures. Pharmacies can be, community pharmacies can be the best place to collect this information because they walk into the pharmacy, they trust them, they can divulge their information. So you can work together with them and monitor their BP, for example, monitor their glucose, for example, and they can come every morning, even if it's an old woman that cannot use that technology, the pharmacy can support her in doing that. And finally, WHO provided a regulatory, a legal and regulatory framework. Thank you. This is the last slide. The legal and regulatory framework for community pharmacies in the European Union. And this framework talks about community pharmacies recognizes that community pharmacies are health professionals most accessible to the public and are cornerstone of primary health care. And it provided the framework on how you can engage them in primary care, including the functions of the regulatory system, what they need to do. We are happy as WHO Nigeria to provide support in adapting this to the context of the country. But I want to say that the ACPN must follow up this with MPACDA and other stakeholders to ensure that we take this forward. This will be provided as a support from WHO Nigeria Country Office. I am very sure Emmanuel from USAID will support this. I am also very sure that our brother Kulani will also do this from the point from Chai. So let's do this together. The conclusion is that we can improve our healthcare coverages and outcomes by leveraging on the availability and accessibility of community pharmacies in the country. Thank you for listening.
Yes, we expected something like that from you, the chairman. Sorry, Mr. Speaker. Well, the speaker has given us everything that we need to know. Otherwise, we would just say there's no need to hear anything, but the panelists have to add so that we have a holistic understanding of what we need to do. Mr. Speaker, thank you very much for that wonderful presentation. We'll go straight to the panelists so that we'll round up because time is of essence and we're already getting out of time. So we call on Ms. Anne E. Patterson, Mission Director, you said, who is ably represented by my brother, pharmacist Oguche. I'm sorry, we'll be giving you only 3 minutes. We can see how you can round up in 3 minutes. I hope you will not ask for extension of time. So we can try and round up. Thank you.
The National Chairman, Acpn, the Chairman of the session, the National Executive Council members of Acpn, fellows of the Pharmaceutical Society and of the Postgraduate College here present, fellow colleagues, ladies and gentlemen, permit me to stand on the existing protocol. I bring you greetings from the USAID Nigeria Mission Director, Ann Patterson. She would have really loved to be here with you, as she really values the contribution of community pharmacists to the healthcare system in Nigeria, especially at the community level, your involvement with primary care. And she is really passionate about the topic, the untapped potentials of the community pharmacist in the delivery of primary healthcare services in the country. The USAID mission in Nigeria has really recognized this over the years, and we have worked assiduously to see how community pharmacists can be empowered to deliver quality pharmaceutical services at the community level. We've had long relationship with community pharmacists. I'm sure a lot of you here may have benefited from the various loans guaranteed by USAID mission in Nigeria through Fidelity Bank and some other banks like the Diamond Bank to empower community pharmacists to improve their capital base to render qualitative services in the community. We have been working and continue to work with the Pharmacists Council of Nigeria to improve the pharmaceutical services of the community pharmacists in the states we support. These activities are currently ongoing, and we've started some activities, and I'm sure the representative of the registrar can attest to that, that we are solidly behind community pharmacists in supporting that we have quality pharmaceutical services at the community level and at the primary healthcare services, involvement of the pharmacist. My brother and friend had talked about what USAID has been doing in the various health care program areas, that community pharmacists are now a point of care for pickup for ARV and HIV medicines in the community. We've been working with community pharmacists to improve access to quality medicines, maternal and child health medicines, malaria medicines in the various states where we work and support. We will continue to do this. And like he said, we've been having serious discussions with the national chairman on how we can continue to empower community pharmacists to support them to play the role that they are supposed to play and well equipped to play at the primary healthcare level, at the community level. Time will not permit me to go further to talk about all the activities that we have with the community pharmacists. But I want to say, to end by saying that the potential that community pharmacists have in primary health care and at the community level is huge. My brother and friend, Tayo, had talked about some of them. We really want to encourage the community pharmacists to tap into these potentials. What can we do better in the area of tax shifting? How can we get involved with government policies that keeps all of these activities? From where I work, if you provide any services or you do anything without record, it means you have not done it. And as pharmacists, we do a lot in the community without records. How are we contributing to the database of the services that we are rendering in the community? How many cases of malaria are the community pharmacists reporting into the national database? SFH just made a presentation on family planning services. How are we recording those services that the various community pharmacists are providing? If you don't record what you do, nobody will know that you're actually doing these services. So please, he talked about the National Health Insurance Scheme. Pharmacists need to get involved with what the National Health Insurance Scheme is doing. Immunization services at the community level, providing primary care to some of the chronic diseases that we have, hypertension, diabetes. These are huge untapped potentials for the community pharmacist. From USAID Nigeria, we will continue to pledge our support to the community pharmacists in Nigeria, that we will continue to support you as much as possible within available resources to ensure that the community pharmacist is well positioned to support us in reaching the unreached at the community level. Thank you so much for giving us this opportunity.
Thank you. Thank you, Yusef, for that brief and well-packed information. We'll call on, I was told that our distinguished senator is indisposed, so we wish him well. We'll call on the representative of Honorable Dr. Shehu Babarebe Shuni, who is a member House Committee on Primary Health Care, the House of Rep, in the person of our dear brother and friend, pharmacist Abubakar Omar. Yes. We'll also give you 3 minutes to share with us.
The chairman of this symposium, please permit me to stand on the already existing protocols. I'm by name pharmacist Abubakar Umar, personal assistant to the Honorable Shehu Balarabe Kakali Shuni on health-related matters, member representing Bodinga, Dengishuni, Tureta constituency. Mr. Chairman, I'm from Sokoto, the hottest place in the country as set by the Society for Family Health. So, SFH, if you are looking for someone from the hottest place in the country, you got one. Let me, on behalf of the Honorable, congratulate the leadership of the National Chairman for organizing such august and unprecedented annual conference, Unity 2020. Actually, you did a lot. To the presenter, I also want to congratulate you for this informative, well-exhaustive presentation, for the role of pharmacists at the community level can never be overemphasized. In addition to the processing of prescription, counseling of patients, community pharmacists respond to symptoms of minor ailments, provision of first aid services, provision of public health services, drug information services, extemporaneous preparations and small-scale manufacturing, traditional and alternative medicines, monitoring of drug utilization, domiciliary services, and agricultural and veterinary practice. As a representative of the Honorable, he wanted to be here to grace this occasion physically, but due to the fact that he'll be engaged at the National Assembly, so he sent a note to me to read out to the Congress. And the note goes as, distinguished ladies and gentlemen, let me apologize for my unavoidable absence at this important annual conference of the Acpn. This is due to the worrisome security situation in the country, which the Parliament is constitutionally required to act upon. Community pharmacy practice as one of the pillars of primary health care and universal coverage and can only flourish in an atmosphere of security, law and order, and vice versa. Therefore, even though I have not been able to attend this program today, let the distinguished members of the association and invited guests know fully well that I am still doing community pharmacy work in the legislative sense of the word in the National Assembly today, debating on matters on national security, economy, peace, and prosperity of Nigeria, which community pharmacy is all about. To this note, I want to thank the National Chairman for inviting me to this August occasion and wish participants a journey mercy to their various destinations. Thank you.
Thank you, our dear colleague. The message Acpn has is that the honorable member is doing the right thing by looking for peace. So we wish him well. And as the person that we may need to make the legal framework, please extend our greeting to him. Thank you. We call on the representative of our double prophet, Elijah Mohammed, the BCN registrar, pharmacist, Baba Shehu. But before that, I have a distinguished gentleman that we need to acknowledge when he's in our presence, a fellow of the FIP, I think the only fellow of FIP, yes. Only black, you see, not only Africa, Nigeria, the only black fellow of FIP. Our dear past president, pharmacist, Oko, I don't know how to, are you a chief? Let me stand up, because I have to stand out to introduce our distinguished colleague. Thank you. Pharmacist Babashehu, sorry, You have only 3 minutes. You have spent 1 minute. For introducing Oko, you have spent 1 minute, so you have 2 minutes. Thank you.
I hope I have not lost another minute. Good afternoon, the chairman of this session. I want to also pay respect to the national chairman of the Acpn and members of the ESCO, our past president in our midst, fellows of PSN, delegates. On behalf of the registrar, I want to congratulate the leadership of Acpn for this program tag Unity 2020, with focus on optimizing primary healthcare services using the community pharmacy. And I believe the keynote speaker has done justice to the topic. As panelists, we only need to give further insights on how to optimize his presentation by way of facilitating recommendations and implementation of some of his recommendations. We do know, sorry, before I go further, let me apologize on behalf of the registrar, who currently is on another official engagement with the registrar of JAM, trying to strengthen or streamline admission requirement of the pharmacy degree program. The appointment happened to have coincided with this event. I want to believe that he will be here for the opening ceremony. Going forward, we should recognize the fact that whereas primary healthcare clinics, primary healthcare centers, and health posts are public sector facilities established for purposes of rendering primary healthcare services, community pharmacies are private sector-driven facilities that are not just supposed to, but critical to the provision of primary healthcare services. And a lot has been said about policies. We can't just walk in the open. We need to be backed up by legislations and policies. And I believe that we currently have what it takes to key into this particular segment of the healthcare and play a great role. Why do I say that? It's because we already know that the Federal Minister of Health has renewed commitment to drive universal healthcare services through, universal healthcare through primary healthcare, and the place of community pharmacies as private facilities cannot be overemphasized in this regard. Of particular importance is the fact that the Federal Ministry of Health has currently put in place the tax shifting and tax sharing policy. Looking into it critically, we have a lot that can be rendered by the pharmacists, by community pharmacies, as it relates to the primary health care. Indeed, PCN play a great role in the development of that document. And for the first time, looking at that document, we've heard about National Strategic Health Development Plan, which of course is the bigger driver for healthcare service delivery in Nigeria. But the tax shifting and tax sharing policy is a component that guides operationalization of the National Health Strategic Plan, Development Plan 2. And I want to confidently inform us that for the first time, we struggled and defended the need to, for the first time, mention the role of community pharmacies as it relates to tax shifting and tax sharing. So from point of government, we already have a backing. And I want to suggest that, I want to believe that we should position ourselves to move with this responsibility. But one thing that is also lacking is the fact that there is need to improve documentation. And it is on this regard that on behalf of PCN, we wish to suggest that there is need for Acpn to urgently develop a standardized framework for reporting of basic services data generated by the community pharmacies on all services provided at their facilities nationwide, such as pharmaceutical care and expanded primary healthcare services, so that all these can go into the National Health Management Information System. Why do we need this data? So we need this data because when we are making cases at policy-making level, we'll be able to have evidence-based information that we can use to make case for our defense. And I want to believe that a lot is being done, except that we are not harnessing them. But not only should we be documenting, let me add that what is of particular importance is that there is need to do this with strong ability to objectively measure and adequately evaluate. Let's ensure that what we are doing is of high standard, such that wherever we are presenting the data, it will be highly accepted. And in this regard, I want to inform us that PCN has commissioned some research projects in the area of services being rendered by community pharmacies. And we are doing this in partnership with academics. Let me state that we are currently about to commission 5 projects. One is assessment of HIV, tuberculosis, and malaria services rendered by community pharmacies in specific states. We also want to assess and document the assessment of CPs in terms of their participation in NHIS. We are also reviewing the range of services rendered by CPs to improve health in its broad sense. We are also assessing, because of the recent outbreak of the pandemic, we also want to undertake assessment of community pharmacists' knowledge and belief, as well as practices in relation to specific herbal products as natural medicines. The essence of all this is to gather data which we can use to support and present to government or policy makers. Let me also inform us that PCN has played a great role in some of the information, the intervention that is being provided by USAID, just like the representative of USAID said. We, PCN, serve as gateway for gain support to HIV-related pharmaceutical services. We also serve as gateway to the USAID intervention in the area of pharmaceutical service delivery for HIV patients. Where we also got successfully in 2012 the approval of the National Council on Health, and I'm worried that we have never made any effort to implement this, where the National Council on Health has approved the fact that community pharmacies can be used for rendering continuation of services for patients on the second phase of TB treatment. Doing all this and having all this documented will promote the image of community pharmacies and also bring to fore the level of the capacity and relevance of community pharmacies in harnessing or in achieving the universal health coverage as being promoted by WHO. On this note, I want to wish the ESCO and the entire membership of FCPN a successful conference, as PCN is always there to support ACPN and pharmacy profession to achieve the very best. Thank you very much.
Thank you, Baba Shehu, or the registrar in the person of Baba Shehu. Yeah, thank you very much. I think that is the end of the symposium. We have heard from the guest speaker, at least as a rundown, the introduction, how primary health care came about, how officially in 1978 it was agreed by governments and the WHO, and how after 40 years in the same Afghanistan, that is in Astana, in 2018, government went, discussed, and still reaffirmed the importance of primary health care. And I also agree that primary health care is still the better way to go, that any government that adhere to and is working with primary health care very well is achieving success more than any other system. The guest speaker also told us so many things on what we need to do, particularly as pharmacists. He agreed, and that if community pharmacists put their hearts together, they are good to go. And he requested that we should have a legal frame that will now enable the community pharmacists to do their work, expecting some incentives. Well, he avoided the word, but I'm using the word because I'm the chairman, because he acknowledged that all the work done by pharmacists in most cases are not even appreciated in terms of monetary appreciation. So he said if these documentations are made and there's a legal framework, much will be obtained from the community pharmacists, because from their training and from their positioning in the community, they will be doing more. The chairman also agreed that inform us that vaccination, as it is, will achieve a better success or more success when community pharmacists are involved. The panelist, the mission director of USAID, represented by our dear brother and friend, Ugoche, did inform us of the efforts USAID have been making. I agree with them that when we talk of diarrhea, malaria, most of the time USAID have done so much. But the problem with community pharmacists, which as the chairman I also agree with them, is documentation. Most of the jobs that are done or the efforts that are done by community pharmacists are not documented. And it's a known fact that what is not written is not done. So if there's no documentation, proper documentation, the work we have done is not known by others. Our dear brother who represented our House of Assembly, House of Rep member, did inform us or appreciate the efforts of community pharmacists. And he said his principal would have been here except for another critical challenge, which is peace. We need peace even to practice. And so if we have crisis at hand, we need to settle that. We appreciated him, and with his prayers, we hope when our issues have come to the House of Rep, I think they will do a good job for us. The PCN registrar is on side. Have informed us that PCN being a gateway to even pharmacy practice, they have been doing so well, dating with both government and other parastatals, particularly the National Health Insurance Scheme. He did inform us that they are working towards providing a good placement for community pharmacies, because most of the time when you are done, they say it's a fee for service. But most of the time when our products that are being paid down, if it's properly done, I think the community pharmacists will smile, I think to the bank also. So thank you very much for listening. We will give, there's no time, but I think if we say there were no question, we'll just take 3 questions, only 3. One this side, 1 here, and 1 there. Just 3 questions only. Okay. Number 1. Wait, number 1. When the big men are pointing hand, you don't know what to choose. Overruled. Okay. All here overruled. Anyone back? No question back. Okay. Okay, we'll give you 2. Okay, very good. Number 3. So, number one.
Good afternoon, Chairman. Good afternoon, the panelists. Good afternoon, colleagues. My question, or will I call it contribution, is to the USAID delegates. Yes. When you were talking, you talked about the that community pharmacists were not, this information you give. See me, I wrote it there, sorry. No, not documentation. It had to do with not providing, not taking advantage of a particular service. Because we observed that in Lagos. Huh? Please, pardon me. Sorry. Okay. Sorry, thank you. No, there's no need. You talked about provision of the family planning services. Then they support the organization as provided in terms of TB and HIV, the drugs. For us, we have been providing the services. But one thing we find is that in the name of tax shifting and tax sharing responsibilities, we find that community pharmacist interests are being jeopardized. Professionalism is being pushed to the background because we say we want to increase access, provide increased access of medicines to our people. What we expect to happen is that the government support, donor agencies and support systems should ensure that they provide resources and mobilize the requisite qualified professionals to the places of need. But rather than this being the practice, what we find is that in the name of creating access, we begin to demarcate professionalism. We begin to find situations whereby even in the cities, where you have more than enough qualified professionals, you find that patents and what have you are being promoted. And this is counterproductive to good health care. Because if the persons who are not qualified continue to be the ones who are the front persons providing this health care, our people's health ultimately will be compromised. So I think we need to re-strategize and see how we ensure that the right professionals, whether medical doctors, whether nurses, or whether pharmacists, are the ones who are in the front of people to provide some of these services. Because if these things continue like this, then I don't think we'll achieve some of the statements we talked about. Thank you.
Mr. Chairman and the House, good afternoon. I just have a comment here and then maybe a few questions. I must commend Pharmacists Council of Nigeria, the registrar and all his team. I was delighted to hear that the council has commissioned certain researches that will be based maybe in the pharmacy just to improve, the reporting of what we community pharmacists are doing in conjunction with the academia. I think this is the greatest news I've had so far in decades. And I want to say this, what we need is evidence-based practice. What we have been doing, we can't continue, like when we attend meetings, they tell us, what is it you are doing? Where is the document? And I think there is a scheming at the Federal Ministry of Health level where people come and it's like, we don't even know what you are doing. Some doctors don't even know there are people called pharmacists. So I wonder where they were trained. So we need evidence-based practice. And that's why I want to please ask Pharmacist Babashir to take this back to the registry that please, we need to have a documentation platform, a system in place where we can record what we are doing. What we find is that with every project, there is a documentation project, platform. a system that we are not able to cope with. We are in family planning, we have one documentation system. We are in HIV, one documentation. It must be integrated. And I think Council, as a regulator, is in a position to be the arrowhead to fashion this out. Then one thing I would have expected the registrar and the team to tell us is about our involvement in the family planning services. I also noted that our keynote speaker didn't mention it. Presently, there is a pilot going, and we have done a lot. Yeah, about a week ago, I was talking to someone that said at least about 290 community pharmacists has been trained, though they call it pilot, they have been trained on family planning services, and we are offering it. We only need to step it up from there. So please integrate and that consortium consisting of Society for Family Health and others. They've been doing a good work, and I think we have tried so far. We only need to expand it and then report it, and then let the permission be given to us to act as PHC in our locality. As Speaker had already mentioned that pharmacies must be made to become also immunization center. Then I want the council to please tell us, recently we had this story about Acpn, one body like that wholesalers can begin to retail now, retailers. We don't know how far that message is. I think we should have a clarification. We want to add value to pharmacy. We should not devalue the practice at this level. And then, recently too, and we are still, I think FIP is still in that mode. Over the past 3 months, FIP has been promoting a course, transforming vaccination globally and regionally. I don't know where Nigeria is. I think it's the work of the Pharmacists Council, the Pharmaceutical Society of Nigeria, and Acpn to champion this cause. Nations of the world on the platform are coming to tell us what they have done. And unfortunately, the day a Nigerian was later to report, the person did not make it. I don't know whether it's because the person is a young person that had to be at work, but just scribbled something down and sent it forward. And I don't think that is befitting for Nigeria, the giant of Africa. So please, sir, Pharmacists Council, the registrar, and the team, please, let's do something about transforming vaccination globally and regionally. And from that, we can take it up. Thanks.
Thank you. Pharmacists, who is number 3? Okay.
Thank you very much. It's been a morning well spent. I just want to encourage the leadership of Acpn. There's one common denominator from what everybody has said. Community pharmacies in Nigeria will do a lot, but very little documentation and very little reporting. And I give it to you. When it is time for negotiation, when we need to speak to the members of the public and the National Assembly, data will be very, very important. So I call on Acpn to please use IT tool for all Nigerian community pharmacists, so that once you are seeing your patients, you are doing your documentation immediately. This will provide a pool of database with which we can negotiate when it is time for that. Secondly, I happen to have written the memo about DOT services in Nigeria that was approved by the National Council on Health. I passed the memo through my Director of Pharmaceutical Services. This is something that has been approved for us, and yet many Nigerians pharmacists are not participating. I also call on the leadership of Acpn to retool and ensure that most people, most community pharmacists partake in this. While we are negotiating for something else to add to our practice, it is also good that the one that we have in the kitty is well managed. Thank you, and God bless you.
Thank you very much. I think there's no question, just advice. So we assume that everybody have heard and have agreed that. Sorry, we have ruled. It said 3 questions. We have. In fact, thank God there was no question. It was just contributions. You said have heard, PCN has heard, and Acpn have heard. They will do something about it. Thank you very much. For that, we have ended this symposium. Thank you.
Thank you, Mr. Chairman. You have done great. Let me welcome the president, my former president of the Pharmaceutical Society of Nigeria, Pharmacist Asubiki Oko. You're welcome, sir. Fellow health person. Well, let me also announce to you that it is going to be compulsory for everybody to wear the face masks in the next session, the opening ceremony. Please, we appeal to all of us. It's critical. We have every reason to do that. We're pharmacists. We will take the products launched by Viata Biotics, but because of urgency of an event that has to happen right now, I will need to appreciate my guests who had come to say thank you to them for their time and how I'm sure we were not, and no one of us is disappointed in our expectations for this session. The message is clear and is loud. So, on behalf of the okay, well, not in a particular order. These are for the panelists. On behalf of the Association of Community Pharmacists of Nigeria, I'd like to call on Mrs. Annie Peterson, the Mission Director of USAID, ably represented by our colleagues, pharmacist Emmanuel, to please take this appreciation. Thank you very much. So on behalf of the Acpn, please convey our appreciation to the Mission Director. Thank you.
Thank you so much. Thank you.
Honorable Dr. Sheu Balarabe Kakale Shoni, ably represented by a colleague, pharmacist Abubakar. Thank you. On behalf of Acpn, we thank you for coming. Please extend her appreciation to the Honorable. Thank you. All right. This is for Pharmacy Dr. Nuruddin Elijah Mohammed, the panelist, registrar of the Pharmacists Council of Nigeria. Thank you. On behalf of Acpn, we want to thank you for agreeing to be a panelist in this session, and thank you for the message we delivered. Thank you. Thank you. Our guest speaker, who is from Paris, we might not be able to send this token to him. So that was why he was not prepared. But I think we will have to appreciate the presenter tomorrow at the session we're going to be having with development partners. So, pharmacies, Hamsat, we appreciate you, we thank you. You have made our job easy. Thank you very much. So I want to also ask that the chairman will still continue to help me pilot. I just got a call to report now at the Senate. So please, particularly because of the opening ceremony, I will have to leave. So Mr. Chairman, we still have one or two things to do. The product launched by Vital Biotics, and I hope we can see There's another presentation, but if not, we will have to take that tomorrow morning. Thank you very much.
Okay. Okay. MC.
Thank you very much. Distinguished community pharmacists, I hope we really had a fantastic time with the symposium session. Quickly, without wasting time, we want to call on the management of Tandem Pharmaceutical Limited, the representative of UK Vitabiotics in Nigeria, for the product launch. Quickly, please.
It also counters the harmful effect of UV radiation and pollution that's found in our environment. And it's actually a synergistic formula of three active constituents: marine collagen, botanicals, and bionutrients. It contains 200 milligrams of marine collagen. We all know that collagen makes up 75% of our skin and keeps our skin looking younger and also aids wrinkle reduction. It also contains botanicals such as grapeseed, pine bark extract, alpha-lipoic acid, and this contributes to collagen formation, cell protection, as well as cell division. And bionutrients such as zinc, selenium, which contribute to the maintenance of hair, skin, and nails. So I'll give the mic over to Dr. Ibekwe, who is going to be explaining to us the science behind skin radiance. And finally, we unveil the product. Thank you.
Good morning, everyone. I'm happy to be here. I'll go straight ahead and talk about the science behind skin radiance. Skin radiance is actually a psychophysical parameter that involves more than simply the quantity of light that is reflected from the skin. This is because for the physicist, radiance is defined as a reflection of light from a source. But when it comes down to the skin, it's more than that. Pettigene defines it as a balanced mixture of skin color, light reflection, and skin texture. For the skin color, we need it to be homogeneously distributed, and the microcirculation has to be right. We don't want there to be too much vasodilatation. Such a person will be too red. And we don't want vasoconstriction. Such a person will be pale. And normally we use the erythema index to measure this. For the light reflection from the skin, this is complicated by the multi-layered structure of the skin. You know, we have the stratum corneum up to the stratum basalis. The stratum corneum actually reflects about 5% of the light that reaches the skin. This is because we have other factors like the smoothness of the skin, the melanin content, which tends to absorb light, and also the collagen, the quality of the collagen. For the skin texture, which is also seen as relief of the skin, other factors that could influence this involves the hydration, wrinkling, scarring, and also the presence of scaling on the skin. How do we objectively measure skin radiance? There are two methods. You could use photography, but with photography, you can measure the skin texture and the color, but you can't measure the reflection because you have the light that is being reflected from the camera. The second aspect is clinical scoring, where you have the combination of coloring, luminosity, and brightness and transparency. As we can see from these three ladies, we could just quickly go through how this is measured. For the color, you need to determine the color saturation that is quite right. Looking at these three ladies, you all agree with me that Halle Berry's color is quite right. It's better than that of Kim Kardashian and Rihanna. You look at the luminescence of the skin, which is defined as intensity of light areas reflected on salient points. If we use their forehead as a form of measurement, you realize that Halle Berry and Rihanna's forehead are too bright compared to Kim Kardashian. Looking at the brightness of the skin, we're looking at the combination of uniformity of the skin color and texture. And in this aspect, Rihanna's skin sort of fails because you can see some areas of hypopigmentation on her forehead. For skin transparency, that's the probability of seeing vessels beneath the skin. We could say that the three ladies sort of have a good score on both on this aspect. How can oral supplementation improve radiance? We have a study that's been proven that this can happen, where you have 35 women that were aged 40 to 70 with subjective assessment of dull reflection. They took 150 milligram of an antioxidant for 8 weeks. And the assessment was done with this CLBT scoring that we just looked at. And they found out that with oral supplementation, the skin color is adjusted quite right. Luminosity of the skin is also adjusted quite right. Imperfections are reduced, but the oral supplementation did not affect the brightness or the transparency of the skin. This is how does oral supplementation affect radiance? It's actually through the process of aging. We all know that aging process is quite a complex biological process influenced by both intrinsic and extrinsic factors. For the aging skin, we know it to be associated with wrinkling, uneven skin tone, loss of elasticity, and whether thickening or thinning of the skin, depending on which area you are looking at it. For the intrinsic aging, we have the buildup of reactive oxygen species, which damage cellular components. And then as we age, the rate at which the skin proliferates decreases, and the collagen as well. The collagen content as well reduces, and even the quality is poor. The extrinsic causes of aging include the ultraviolet light damage, which is from the sun, environmental pollution, and as well as smoking. Genetics seems to stand on its own because that is based on the individual. For anti-aging strategies, the main paradigm of successful aging is the focus on health and active participation in life. Most times, people think that to be able to successfully treat someone or to take care of aging process, that the skin has to be healthy, smooth, blemish-free, translucent, and resilient. But I need to warn here that it is not necessary to look better, is not necessarily the same as to look younger. We need to have full communication with the patient and know that the approach is multidimensional. Using antioxidant to take care of aging, what it does is it neutralizes the free radicals, repair oxidized membrane, decreases the reactive oxygen species production, and also acts as a photoprotection against UVB. For Perfectil that we're launching today, a study has been done, and one of what it was proven to show was that it reduces the roughness of the skin, especially during the winter period, and also that it is quite safe. And borrowing the words from Professor Philip Herbert, I would like to conclude by saying that the results of the trial showed that women or men who wish to protect their skin against the harmattan would consider a supplement such as Perfectil. The dry and cold harmattan weather has a great influence on the condition of exposed skin, affecting the face the most. Year after year, these changes in roughness, skin thickness, and elasticity lead to visible skin aging. Thank you.
Thank you very much. Perfectil Platinum is distributed in Nigeria by Tandem Pharma Limited. You can reach them on their phone number and email address. So at this juncture, we would like to call on some pharmacists to help us with the unveiling of the product Perfectil Platinum. I would like to invite the Acpn National Chairman, Pharmacist Samuel Adekola. And also, I would like to invite the representative of the registrar, Pharmacist Ibrahim Babashehu Ahmed, FPSN. Sir, please, can you help us with the product unveiling? Who also is the Director of Research and Statistics, PCN. I also want to invite Acpn National Secretary, Pharmacist Abosede Idowu, to please come forward. I would like to invite pharmacist Mrs. Biola Paul Ozier. She was the immediate past chairman, Acpn Lagos State. Ma, please, can you come up? I also want to invite Dr. Foyibo Ejiro. She's the deputy president, PSN South. Ma, please, can you come forward? And I want to invite the MD of Tandem Pharmaceuticals, Pharmacist Okechukwu Okonkwo, to please join us. And finally, I would like to invite the MD of Vanguard Pharmacy, Pharmacist Taufik Odukoya, to please join us on the stage. And also a representative from Acpn Abuja. I don't know, do we have any representative from Acpn Abuja? Please, can you join us on the stage? Sorry? Or if the chairman is available, please, can you come up? Thank you. Yes, sir. Okay, no problem. So you just see.
Distinguished colleagues, in a person, what you see first is the skin. True or false? True. Yes. So, thank God you are saying mask. You didn't put the mask, so you can see your skin. Whether you put mask and everything, you see your skin. So if there's anything to make your skin radiant, I think that is very good. I'm sure maybe before we go, all of us will buy this product. And when we come next time, our faces will not be the same. Yeah. Thank you very much. And so, our distinguished guest here, sorry, my chairman, he's the vice chairman, Commonwealth Pharmaceutical Association. Yes. So, if I don't recognize her, she will sanction me as a member of the Commonwealth Pharmacist. So, and the regional is the regional representative, West Africa, and our counselor, Nigerian counselor also. Mr. Vice Chairman, thank you. Sorry, I'm not biased. I'm just greeting her. I didn't greet her since she came, that's why. And so we are unveiling this. I've not been told of procedure of unveiling. So can you brief me more? What do you want us? You see, I was not just biased. Our vice chairman, vice president, Commonwealth Pharmacy Association, our regional representative, West Africa, and our Commonwealth, I'm going from Commonwealth Councillor, and our Deputy President, South, you will be the one to unveil this for us. And so they will lead you. Me, I will do the counting. Me, I will do the counting. Definitely, when you are doing the unveiling, you need somebody to assist you. The secretary of, the secretary of Acpn, you will join. You will also be the one to support them behind. So, by the authority of the chairman, I'm giving you the directive that you should follow them. Because it will not be all women affairs. Because Joe Biden have just given all women in the White House. So we will not do that one. I will join them. Thank you. We'll open from the back now, from the front now, so that these people will see it. So at the count of 3, 1, 2, 3. This one's now fire.
Thank you very much for your time. The products are actually available at the stand, and before the end of this program, we'll make our gifts and products available to us. Thank you.
Distinguished pharmacist, I want to believe it has been a very, very rewarding session so far, talking about the opening symposium. Rebecca, what do you think about it, especially the topics that were discussed?
Very deeply discussed. We've always known that we have a place with primary health care, but now we've been given strategic things to do. Proper documentation, and then we're hoping that at the top where it matters most, we'll be given the due recognition that we need so that we can actually become global, because the whole idea is to practice with a standard that is global and not just being local champions.
Wow. Thank you very much. One of those key salient points that was actually raised at this symposium is the fact that primary health care is very key to the achievement of universal health coverage. The speakers also jointly agreed that to achieve a good primary health care should also comprise of pharmacists. Community pharmacists will precisely play a key role in primary health care, meaning that community pharmacists is key to the achievement of universal health coverage. And of course, this is what the WHO said in 1994 when they said the community pharmacist is the most accessible healthcare professional in the world. I think we deserve a round of applause. So quickly, we want to also announce to the participants at this conference that local food vendors, they've been set up behind the admin block of the ICC for those of us that have been making serious requests.
Special appreciation to Tandem Pharmaceuticals, and we hope that the business goes forward. Thank you for representing Vita Biotics UK and bringing Perfectil Platinum to Nigeria. Thank you very much. Let's put our hands together for Tandem Pharmaceuticals Limited. With this, ladies and gentlemen, we would love to specially appreciate every dignitary that has been invited here and have been properly represented. We would go ahead and appreciate Honorable Pharmacist John Enger for chairing the session in a very distinguished manner. He did it so calmly and yet very detailed. Thank you very much, sir. We're glad to have you.
Let me also appreciate Mr. Federico Gruani, the Deputy Head of Organization for Economic and Cooperation Development, ably representative of our very home pharmacist, Dr. Omotayo Hamzat. We appreciate you. We appreciate the representative of the PCN registrar. We want to appreciate every fellow that participated in this symposium. And of course, our appreciation also goes to every community pharmacist herein present. Without you, this wouldn't have been. Let's also quickly remind you that as at 3 o'clock, the grand opening ceremony of the 39th Acpn conference will be live and direct. It promised to be very, very interesting. Dignitaries are already on board, on ground to grace the occasion, and you can't afford to miss it. Rebecca.
So with this, we have officially come to the end of this session, this symposium session. You were present, so you deserve an applause. You deserve all the accolades you can get. So please put your hands together for yourselves, men of honor. Thank you so much. Thank you so much for coming. Please just go back, refresh, and put on your best traditional attire as we grace this occasion of the 39th Annual National Conference of the Association of Community Pharmacists, where we have the grand official opening of this event. Thank you very much, ladies and gentlemen, and see you by 3 p.m. Thank you.